So we know now that hematological toxicity is a really important component of toxicity in patients receiving CAR T-cell therapies. And we've previously developed a risk stratification system termed CAR-HEMATOTX, which differentiated between patients with a high versus low risk of hematological toxicity in LBCL. But it was really unclear if there was a diagnostic utility in patients receiving brexu-cel for relapsed refractory mantle cell lymphoma or ide-cel, cilta-cel for relapsed refractory multiple myeloma. And so in these multicenter retrospective analyses, we studied for myeloma, it was 113 patients, for mantle cell lymphoma, it was 103 patients. And we studied hematological toxicity, infectious complications, but also treatment outcomes in these patients. And we find that the CAR-HEMATOX score indeed identifies patients with a high risk for prolonged neutropenia. We also identify that patients have a higher incidence rate of severe infections. So for instance, for mantle cell lymphoma, the rate of severe infections, which are infections requiring IV anti-infective therapy and/or hospitalization, it was 30% versus 5%. And it was particularly for bacterial infections, where it's severe bacterial infections, 28% versus 5%. What was also striking, I think, in both cohorts, really, was the importance of non-relapse mortality, and particularly in what way that infections really were the driving force of non-relapse mortality. So, for instance, in mantle cell lymphoma, we observed a non-relapse mortality rate of about 10% in the first year after CAR T-cell therapy. And for multiple myeloma, it was 6%. And for the HEMATOTX score, we identified that the patients that had a high risk also had a higher rate of non-relapse mortality. And then finally, I think what's important is also treatment outcomes. So the score, which integrates both components related to hematopoietic reserve, but also baseline inflammatory state, it's determined prior to therapy initiation, before lymphodepleting chemotherapy. And we find that there is a significant difference in both PFS and OS and response rates for both the patients receiving BCMA-directed CAR T-cell therapy and also brexu-cel for mantle cell lymphoma. So I think the question really is, what are the clinical implications of this? And I think what's really important is that we can identify high-risk candidates for hematological toxicity, but also for infectious complications. And what that means is that we can probably identify high-risk candidates. These are patients that may benefit from antibiotic prophylaxis, maybe even antifungal prophylaxis. They fit within the guidelines, the ide-cel guidelines for these prophylactic measures. These may also be patients that are good candidates for prophylactic G-CSF or early G-CSF. And on the other side, the patients that are low risk, so a low HEMATOTX score 0 to 1, these probably are patients where we may be able to withhold antibiotic prophylaxis. These may be patients that are also good candidates for outpatient management. And I think finally, the fact that the score stratified for treatment outcomes warrants further study, may be integrated with other measures such as metabolic tumor volume in these patients.